When auscultating, it's important to know your stethoscope. The diaphragm is better for detecting higher-pitched sounds, such as S1 or S2, the murmurs of aortic and mitral regurgitation, and pericardial friction rubs. The bell is more sensitive to low-pitched sounds, such as S3 or S4, and the murmur of mitral stenosis. When auscultating the heart, remember to correlate your findings with the patient's jugular venous pressure and carotid pulse. You will listen for S1 and S2 in each of the 6 listening areas. In the aortic area, in the right second interspace close to the sternum. In the pulmonic area, in the left second interspace close to the sternum. In the left third interspace. In the tricuspid area, in the left fourth and left fifth interspaces, and in the mitral area at the apex. The auscultation sequence will start with the diaphragm of the stethoscope and progress from the base of the heart, moving from the right second interspace to the left second interspace and down the left sternal border to the apex. Then, with the bell of the stethoscope, we will listen along the lower left sternal border in the left fourth and fifth interspaces. Then we will listen at the apex. Adjust your stethoscope so that you will be listening through the diaphragm. Begin listening in the aortic area at the right second interspace close to the sternum. Starting in the right second interspace helps orient you to the cardiac cycle. Note the cardiac rate and rhythm. Normally the rate is 60 to 100 beats per minute, and the rhythm is regular. Identify S1 and S2, and listen for extra heart sounds and murmurs. Murmurs are covered in greater detail later in this video. In the aortic area, and also in the pulmonic area, S2 is usually louder than S1. Still listening in the aortic area, but focusing more in the pulmonic area. Try to identify the inspiratory splitting of S2 into its 2 components. Its first component, A2, is from left-sided aortic valve closure. Its second component, P2, comes from right-sided pulmonic valve closure.